because it is storing glucose, it is stopping the breakdown of glucose, it is increasing the fatty acid synthesis, it is decreasing the breakdown of fats. So it's mainly an anabolic hormone. If you see on the other side, all other hormones are causing increased glycogenolysis, increased gluconeogenesis, increased lipolysis. So all others, glucagon, epinephrine, cortisol, growth hormone has only one synergistic effect with insulin, which is protein synthesis. But the rest, all the hormones are doing catabolism. So they are going to break down carbohydrates from the glycogen to glucose. They are going to convert non-carbohydrate source into glucose. They are going to increase lipolysis. They are going to increase the protein catabolism, except the growth hormone. All the other hormones are doing all these actions which you are seeing, which are opposite to the insulin. That's why when you have deficiency of insulin, you have no other hormone to compensate for it. If you have a deficiency of glucagon, you still have epinephrine. If you have a deficiency of cortisol, you still have growth hormone, which has similar effects on metabolism as the other hormones. So there are several other hormones which have similar effects, but insulin is the only pure anabolic hormone. So the deficiency of insulin cannot be compensated by any of the other hormones. So you can see why deficiency of insulin cannot be compensated, because you would see that it is causing glycogenolysis, gluconeogenesis, decrease in gluconeogenesis, decrease in ketogenesis, decrease in lipolysis, while all the other hormones are increasing glycogenolysis, increasing gluconeogenesis, increasing ketogenesis, increasing lipolysis. Now we are coming to glucagon. Glucagon is secreted by alpha cells, which are on the periphery of the islets of Langerhans. Is secreted when the blood glucose concentration falls. So when you have low blood glucose level, you have glucagon to increase the blood glucose levels. So how it is going to do it? Uh, has several functions. So it is a mirror image of the insulin. So whatever insulin was doing, it is doing opposite to the insulin. Molecular weight is 3,485, composed of a chain of 29 amino acid. When purified glucagon is injected in an animal, it causes profound hyperglycemia. So it is a hyperglycemic hormone similar to cortisol, similar to growth hormone, similar to epinephrine. So epinephrine, cortisol, growth hormone, glucagon are all going to increase the blood glucose level. So effects of glucagon on glucose metabolism, it will cause the liver to do breakdown of glycogen into glucose. It would increase the gluconeogenesis, so it would increase the glucose to be converted, non-carbohydrate sources to be converted into glucose. So glucagon causes glycogenolysis and increased blood glucose concentration. The most dramatic effect of glucagon is its ability to cause glycogenolysis in the liver, which in turn increases the blood glucose concentration within minutes. So like epinephrine, glucagon can also increase the blood glucose concentration by breakdown of glycogen in the liver to glucose. So within minutes, you have blood glucose level going up, like which happens with epinephrine. So epinephrine and glucagon can increase the blood glucose level very quickly, while cortisol and growth hormone will take it long time to increase the blood glucose level. So the major action of glucagon are to increase glycogenolysis, increase gluconeogenesis, increase lipolysis, increase keto acid formation. All this was decreased by insulin. All this is increased by glucagon. So effect would be increased blood sugar level, increase fatty acid levels in the blood, and increase keto acid levels in the blood. How it does it? At the cellular level, glucagon activates the adenyl cyclase cyclic AMP, which activate protein kinase regulators, which will phosphorylate, phosphorylase B and A, promotes the degradation of glycogen into glucose 1 phosphate, which is then dephosphorylated and glucose is released from the liver cells to the blood. So, what it is doing, it is converting glycogen back to glucose. Again, this is the source is alpha cells, promotes glycogenolysis, gluconeogenesis, lipolysis, ketone production, elevates blood sugar level, maintains the homeostasis when the concentration of blood glucose level falls too low. It is secreted in response to hypoglycemia, inhibited by insulin, hyperglycemia, and somatostatin. Yes. Yeah, so when you would have glucagon secreted, your glucagon is going to increase the blood sugar levels. And when you have high blood sugar levels, you would have insulin to, insulin would be stimulated by high glucose levels, which would, so that is the reason. Glucagon increases the blood sugar level, and blood sugar levels stimulate the insulin secretion.
But it also says that glucagon itself stimulates.
It can also, because you would find that there are, the hormones can themselves in the islets of Langerhans can stimulate the beta cells. Yeah. So, importance of blood glucose regulation. Glucose is the only nutrient that normally can be used by brain, retina, and germinal epithelium of gonads in sufficient quantities to supply them optimally with their required energy. And most of the glucose formed by gluconeogenesis during interdigestive period, when insulin is low, is used for metabolism in brain. Uh, so, what would be the consequences of high sugar levels in the blood? If you have high blood sugar level, why this is bad for the body? Why hyperglycemia is bad? Why diabetes? In diabetes, you have the main thing is hyperglycemia. So, what is going to go wrong in the body because of hyperglycemia? If you have hyperglycemia, you would have high osmotic pressure in the extracellular fluid, which will result in the water from the intracellular compartment to move to the extracellular compartment, leading to dehydration of the cells. Loss of glucose in urine, since high glucose concentration in plasma will result in the filtered load which is going into the renal tubules will be much more larger than it can be absorbed. So a lot of glucose would be lost in urine. So as the glucose would be lost, there would be more water which is going to go with it. So this would lead to dehydration. Long-term increase in blood glucose may cause damages to many tissues, including vascular tissue. How? Because the proteins in the tissues will become glycated. So if you have high levels of glucose in the blood, it would cause glycation of proteins in the vascular tissue, causing damage to the small vessels and larger vessels. So, glycation of proteins in the blood vessels can lead to small vessel disease and large vessel disease. So, one is the osmotic damage, dehydration, and then glycation of different proteins because of high blood glucose level in the vascular wall can lead to damage to small vessels and large vessels. Now there are two types of diabetes. There's one is called the type 1 diabetes because of insulin deficiency. There is the islets of Langerhans are destroyed by an autoimmune process. So the beta cells are not sufficient enough to produce enough insulin. So insulin dependent diabetes is more of an autoimmune disease which affects in the damage of the beta cells, and if you have deficiency of the beta cells you cannot produce enough insulin. On the other hand, type 2 diabetes is a non-insulin dependent diabetes which is mainly because of insulin receptors. It's not because that you don't have, you might have a little bit of insulin deficiency, but there is not that much lack of insulin. The problem is that the target tissues have become resistant to insulin. So even if you have insulin, you would not be able to absorb sugar. So when you are going to look at the insulin levels in type 1 diabetes, they would be very low. But in type 2 diabetes, you would have high blood sugar and high insulin because there is resistance to insulin. So, how would the diabetes present? You would have polydipsia, that means you would have a lot of thirst. Polyuria, that means a lot of urine is fast because as the glucose is going through the urine, it is going to take a lot of water with it. There would be polyphagia, you would feel hungry because you have low glucose. Glucose utilization is low, and so you start to feel hungry. So there is a lot of polyphagia. You eat a lot. Weight loss, especially in type 1 diabetes, because there is catabolism of protein. So you would have, there's lipolysis, and there is protein catabolism. So there would be a lot of weight loss. There is a complication of type 1 diabetes, which is called diabetic ketoacidosis, which we are going to talk about in a few minutes. What is DKA? So this DKA, which is written here, is diabetic ketoacidosis, which is a complication which happens in type 1 diabetes. And similarly, there is a state which is called the hyperosmolar hyperglycemic state, which is also a complication, but it happens in type 2 diabetes. So DKA mainly happens in type 1, and hyperosmolar hyperglycemic state happens in type 2 diabetes, which is a complication of type 1 and type 2 diabetes. Rarely you can have diabetes caused by unopposed growth hormone or epinephrine. So if you have a tumor which is producing a lot of growth hormone, you can have diabetes because of that. You would have hyperglycemia because of that, and you might have hyperglycemia because of a tumor producing a lot of epinephrine. Also seen in patients with glucocorticoid therapy. So if you are going to give steroids to people for autoimmune disease, it can also lead to diabetes or hyperglycemia. Complications. So complications would be because of non-enzymatic glycation, because if your blood glucose level are going to be up, they are going to glycate several proteins. This will result in a small vessel disease and large vessel atherosclerosis. Small vessel disease can cause retinopathy, it can cause neuropathy, it can cause progressive proteinuria through the glomerulus, leading to renal failure later on. Large vessel disease can involve coronary artery disease, peripheral vascular disease of large blood vessels in your limbs. So glycation, non-enzymatic glycation, can cause damage to small vessels as well as large vessels. If you have small vessel disease, you might have end up with retinopathy, renal disease, neuropathy can happen, and with large vessel disease, you can have coronary artery disease. You can have occlusion of your large blood vessels like femoral artery, popliteal artery. Those big vessels can be affected. Osmotic damage can result in mainly neuropathies and cataracts. So cataracts and neuropathies. So you can develop cataracts or opposition of your lens in the eye, or neuropathies, which you see sensory and motor type of glove and stocking neuropathies, which happen in diabetes, happen because of osmotic damage. You would learn about the pathogenesis more in third year, but the major thing is that there might be glycation of proteins, or there might be an osmotic damage to the tissue. Glycation will result in small vessel disease and large vessel diseases, while osmotic damage mainly result in neuropathies and cataracts. So this is the difference. Type 1 diabetes is an autoimmune destruction of beta cells, while type 2 diabetes is more of a resistance to the insulin. with progressive pancreatic B cell failure. So uh, there is resistance. So what would happen? There would be more insulin produced by pancreas because you have a sustained hyperglycemia. So over the time when islets of beta cells would continuously excessively secrete insulin, they would fail. So in type 1, there is an autoimmune disease which is destroying the beta cells. In type 2, what is happening is that insulin resistance is there. So there is hyper insulin secretion from the beta cells, which will ultimately result in beta cell failure progressively over time. And over the top of it, what we do in treatment of type 2 diabetes, that we give these drugs like sulfonylureas, which will increase the insulin secretion from the beta cell. So already insulin is excessively secreted by the beta cells, and you are pushing the beta cells to produce more insulin. So what would happen? Over the period of time, beta cells will fail. And once the beta cells are going to fail, you are going to become insulin dependent diabetic. So initially you see the type 2 diabetics, they are given drugs, and then after a few years, their beta cells fail, and then they become insulin dependent. Okay?
So
Yeah.
exogenous insulin,
Yeah.
would it be, would it be for indication? Would it be for only the insulin dependent?
It should be for the insulin dependent because the autoantibodies are destroying the beta cells. But what happens in the type 2, initially they are given drugs to increase the secretion of insulin. Now beta cell, this is the treatment which we started with, because that's the only drugs which we used to have, that to increase the secretion of insulin. And now we know that type 2 diabetes is mainly the problem with the resistance to insulin. So we need to decrease the insulin resistance rather than increase the insulin secretion, because already beta cells are secreting more than their capability. If you are going to push them more, ultimately they are going to fail. And once they are going to fail, you are going to become insulin dependent diabetic. So insulin is necessary for the treatment of type 1 diabetes, but it is sometimes necessary when the beta cells are going to fail, you are going to become insulin dependent diabetic. Age usually less than 30 years, even you can find a type 1 diabetic in 3-4 year of age or 5 year of age or under 10. You would be able to identify type 1 diabetes because it is an autoimmune disease. Uh, Type 2 diabetes usually happens in later years of life when you become obese, and as you become obese, you are becoming insulin resistant. So obesity over the period of time will make you insulin resistant. So it is usually found in people after 40 years of age. There is no association of obesity with type 1, but type 2 diabetes, you would usually find people who are obese, and that's why they are insulin resistance. Genetic predisposition, relatively weak. There is a very strong, genetic predisposition for type 2 diabetes. So it's not only that you are obese that you are more predisposed to type 2 diabetes. You could be genetically predisposed also. So if you have your sibling or your parents or somebody who's diabetic, then you have, more chances of developing type 2 diabetes. There is an association of HLA with the type 1 diabetes. There is no HLA association with type 2 diabetes. There is a severe glucose intolerance, while there is mild to moderate, because here you have insulin resistance. Here you don't have insulin at all. So any glucose you are going to give, you are intolerant to it because you cannot absorb glucose because you don't have insulin. You have high sensitivity to insulin. There is very low sensitivity to insulin in the type 2 diabetes. Ketoacidosis is common. Here it is rare because these guys have no glucose to use. Their stores are also gone. So they are more dependent on keto acid for energy. Beta cell number is very low here. There is variable. Serum insulin level would be low, here would be higher. you mostly higher. It's written variable, but mostly in type 2 diabetes, unless it has gone into failure, the beta cells, you would find high insulin, high glucose levels. Classic symptoms are common. Here, you would not find classic symptoms of diabetes in type 2. Histology will show leukocytic infiltrate, while here you would see amyloid peptide deposits within the beta cells. So, what insulin deficiency will do will result in decreased glucose uptake, will result in increased glycogenolysis, will result in increased gluconeogenesis, increased proteolysis, and increased lipolysis. These are the main effects of insulin deficiency. So now, because of this will result in hyperglycemia and glucosuria. That means you would have increased blood sugar level and excessive glucose going out from the urine. This increases the plasma osmolarity and it increases your thirst. This also increases osmotic diuresis. So as the glucose is passing through the kidneys, it is taking the water with it, which will result in loss of water, sodium, and potassium, resulting in hypovolemia, decreased circulation, failure, tissue perfusion, coma, and death can happen if you dehydration is to that extent that you continuously pumping out water, sodium, potassium, everything, you would become hypovolemic and ultimately there would be circulation failure. Uh, Gluconeogenesis, there is decreased protein and there is weight loss because of proteolysis. Lipolysis will increase the plasma fatty acid levels, which will increase keto acid, and this will result in ketonemia and ketonuria, which will lead to, when you would have high levels of keto acid, you would have metabolic acidosis. So there is an anion gap metabolic acidosis, which can lead to hyperventilation. You start to breathe because you want to take out carbon dioxide. You start to breathe faster. Uh, Circulatory failure can lead to serum lactate levels to go up, which is also going to add up with metabolic acidosis. So metabolic acidosis can happen because of ketoacidosis and also because of increased lactic acid production. How would you diagnose diabetes? You look at the glycated hemoglobin levels. So if the glycated hemoglobin levels, hemoglobin A1C for the period, it shows you the blood concentration of glucose for the last 3 months. So if it is more than 6.5%, then you have diabetes. It's a diagnostic test. You do hemoglobin A1C, and if it is more than 6.5% glycated hemoglobin, you definitely have diabetes. Fasting blood glucose level more than 126 milligrams per deciliter also is diagnostic. And the other thing which you do is a 2-hour glucose tolerance test. You give 75 grams of glucose orally, and after 2 hours, you look at the blood glucose level. If this is more than 200 milligrams per deciliter, you are diagnosed as diabetic. So these are the three major tests which are used to diagnose diabetes. Now we are coming to one of the complications of diabetes type 1, which is the diabetic ketoacidosis. So, and it is one of the most feared complications. So when you have, uh, sorry, when you have insulin which is low and or non-compliance, you have are insulin-dependent diabetic, and you forgot to take insulin, or you may have a severe infection where your requirement of insulin has increased, but you are taking the similar amount of insulin. So what happens? So when your requirement of insulin increases, or you have stress like infection, or you forgot to take your insulin and you ate, excessive fat breakdown will start, which will increase the ketogenesis, and this will result in metabolic acidosis, as well as when you would have high amount of blood glucose. What it would do, it would take the water, the extra cell, it would dehydrate the cells, and also it would move the potassium out from the cells. So there would be hyperkalemia, but intracellularly the potassium would be, the total potassium content would be low. So what is the sign? You have coma-like situation. You have pulmonal breathing, rapid breathing because you have acidosis. You have abdominal pain and vomiting, dehydration, and you have fruity breath of acetone because you are producing a lot of ketoacids. So in the labs, you would see hyperglycemia, hydrogen ion concentration would be up, bicarb would be down, so it's metabolic acidosis, increase blood ketone levels, you would have hyperkalemia, blood potassium levels would be high, but total potassium intracellularly is low. There is osmotic diuresis, so there is a lot of potassium loss and total potassium is depleted. uh, Complications, it can lead to cerebral edema, cardiac arrhythmias, other things. But how you are going to treat? You need to replace the IV fluids, and because you don't have the insulin, you need to give insulin, and you need to give some glucose, because only if you give glucose, potassium is going to go into the cell. So you know that potassium moves with glucose, and you have extracellularly high potassium and intracellular potassium is low. So you are going to, although this guy is hyperglycemic at the moment, it has 400 or 500 sugar levels, but what you do, you replace IV fluid, you give insulin with glucose, and then replace potassium, because otherwise potassium is not going to go into the cell. You need glucose for potassium to enter into the cell. So this is the treatment of diabetic ketoacidosis. You need to understand that people with type 1 diabetes, if they are in stress or infection or anything, it would increase their insulin requirement. And if they are not taking that insulin, their blood sugar levels are going to go up, resulting in ketogenesis, and ketogenesis is going to result in metabolic acidosis and dehydration and all those type of things. So you need to replace IV fluid, you need to give IV insulin, and potassium needs to be replaced, but with glucose, so that potassium can move inside the cell. Because there is the total potassium of the is not that much, but serum potassium levels are high because potassium has moved out of the cell. Now you have to push it inside the cell. So you need to use glucose to push potassium inside the cell. The other complication which you can have is the hyperosmolar hyperglycemia state, which usually happens with type 2 diabetes. So there is excessive osmotic diuresis, dehydration, and eventual setup of the hyperosmolar hyperglycemia. So in these patients, what you are having is that there is no insulin uh, deficiency, but these are more of insulin resistant people. So symptoms of this would be thirst, polyuria, lethargy, some focal neurological signs like seizures, and can progress to coma and death. If you look at the lab, the hyperglycemia here is going to be huge. You would see, somebody with 800 milligrams per deciliter of blood sugar level. Normal is between 80 to 120 milligrams. And in diabetics, you usually see around 170, 180, maybe 200 plus. If you are seeing diabetic ketoacidosis, you would see somewhere around 300 or 400 milligrams of deciliter in terms of the sugar levels. But if you see somebody with 600 to 800 milligrams per deciliter of the sugar level, he is or she is in hyperosmolar hyperglycemic state. And in this, because you have that much of sugar level, the serum osmolarity will go up. There would be no acidosis. In that, there was, acidosis because you are unable to utilize carbs, so your metabolism has shifted to fat because you have no insulin. Here you have insulin, but there is insulin resistance, and you have too much sugar. And because of that, you would have increased serum osmolarity, but no acidosis. So there is no metabolic acidosis in hyperosmolar. What you do is give IV fluid and insulin therapy so that you can dehydration of the intracellular dehydration can be treated, because if you have hyperosmolar state, all water from the cells is going to move out. Yes.
So why is acidosis?
Yeah, because in type 2 diabetes, as we said, there is deficiency of insulin, but there is no total loss of insulin. And here the sugar levels are that much, he can still utilize glucose for energy. So that the metabolism is not completely shifted towards fatty acid and production of keto acid. So there is no excessive production of keto acid in this state. In type 1 diabetes, your metabolism is shifted towards production of keto acids. That's why you have metabolic acidosis.
Isn't the insulin resistance is like doesn't have an insulin?
No. Insulin resistance means that you have insulin, but your tissues cannot utilize enough of the insulin to absorb glucose.
It's like the patient doesn't have an insulin, so there is no glucose.
No, it's not exactly like the insulin, because insulin is being produced, but the tissues have less sensitivity to insulin.
Can use insulin.
Can use insulin, but the sensitivity to insulin is decreased. Okay? Yeah.
In type 1 diabetes, isn't the patient is hyperglycemia, having hyper?
Yeah, he have hyperglycemia, but the hyperglycemia in type 1 diabetes, like in DKA, can reach up to 300-400 milligrams per deciliter. But here, in hyperosmolar hyperglycemic state, the blood sugar level is about 800, 1000 milligrams per deciliter, which is, double what you even expect in the in diabetic ketoacidosis. So the major effect here is, because you have too much of glucose in the blood, it would actually push all the water from the cell to the extracellular compartment, leading to polyuria and polydysphia. You're peeing every sugar and water out of your body. So mainly you are dehydrated. So what you need to do is you need insulin now to push sugar into the cell, and the other thing which you need to do is IV fluid, so that dehydration can be treated. Okay.
But can't you use glucose as an energy source in type 1?
In type 1, you don't have insulin. How would you use the? You don't have type insulin, so you are unable to use glucose as an energy source. Okay. Glucagonoma is a tumor of the pancreatic alpha cells which overproduce glucagon, and this presents with dermatitis, diabetes, deep venous thrombosis, declining weight, depression. So this is a tumor of pancreatic alpha cell, and it presents with diabetes because it would increase the blood sugar level. It can also cause coagulation in the blood vessels in the veins. So deep venous thrombosis, declining weight, and depression are also signs of glucagonoma. Insulinoma, we have already talked about in the histology section. We did talk about the tumor of beta cells of pancreas, which produce overproduction of insulin, leading to hypoglycemia. So these guys will have hypoglycemic attacks. They will find, their blood sugar level around 40-50 milligrams per deciliter. So they have a tumor which is continuously producing insulin, and that will result, and it's not responsive to glucose. It's just continuously producing insulin. So as a result, they would have hypoglycemic attacks. So there is a Whipple triad. So low blood glucose, symptoms of hypoglycemia, and resolution of symptoms after normalization of glucose level. If you start to look at these patients, they would have low glucose level and high C-peptide level. Why high C-peptide level? Because it is the endogenous insulin which is being produced. So they have high C-peptide level, low glucose level. If you see patients with diabetes mellitus type 1, they may have hypoglycemia, but when they take excessive exogenous insulin. So when you are going to look at those patients, how would you differentiate between a type 1 diabetic who has taken large dose of exogenous insulin is by looking at C peptide. So what you are seeing in these, how would you differentiate insulinoma with a type 1 diabetic patient is that you are seeing the C peptide high, low blood glucose level. In type 1 diabetes, you would have low glucose because of if excessive amount of insulin is taken, but C peptide would also be low. Okay? Everybody understand this? Thank you very much. We'll stop here. If you have any questions, I am ready to answer. Yeah, yeah. Go ahead.
upload your slide.
Sure.
Doctor, regarding these tumors, are they progressive or congenital?
No, usually they are benign tumors. Insulinoma is also a benign tumor, and glucagonoma is also a benign tumor. It's not a malignant tumor. Yeah?
Is it malignant?
It is not malignant. They are usually benign tumors. Yeah.
So the hyperosmotic incident, you have mentioned there is no acidosis, right?
Yeah, there is.
Because the insulin resistance.
Yeah, because this happens in type 2 diabetes.
Yeah. So why would we treat him with insulin therapy?
Yeah, because what we
Or
see.
is it
Yeah, but the blood sugar levels are very high. So now you want to push this glucose into the cell. How would you do that?
we already in resistance to
Yeah, but you need to give insulin so that excessive insulin so that you can push the glucose into the cell. Otherwise, all the water is going to move out.
So the insulin, the over insulin concentration will overcome the resistance you need.
Yeah, because if you have resistance. So if you give extra insulin, the